I've been asked to talk about IT as an imperative tool to enhance the quality of patient care as surgeon's perspective. I thank the organizers, Dr. Voleti Chaudhary sir and Mr. Kannan for giving me this opportunity. Let me see, I'm not only a surgeon, I'm also an epidemiologist, I'm also an IT guy. So let me put up and see how best I can put all together and see how IT really helps us. So when we look at healthcare is evolved over a period of time, and we look at information as very important thing. If you take a normal doctor sitting in a village, how does he treat a patient? He's basically based on his knowledge. He treats the patient, and you would have done very well, and you ask him, how did the treatment work? He may say, I've done about 50 surgeries or taken care of 100 patients of this disease and it worked very well in my hand. But actually, is it really true? We don't have any evidence because he doesn't have the data. So we have moved into an era where it's all evidence-based medicine, and we need to collect information from various sources. If the information comes from, not only from, even from a pharmacy can give you the information. If I want to look at a prevalence of dry eye in a community, I can go and ask my local pharmacist and see how many dry eye prescriptions have been given. It gives you information about how the prevalence of dry eye in the community is. So there are a lot of information which is being happening, and with this information you get it from your clinical trials, drug discoveries, PAC system. So we can do real analysis and look at the evidence-based medicine. And this also gives you idea about the business intelligence, good workflows, how to modify the workflows in case we need to start a new branch, a satellite center. If we get a lot of patients coming from that particular center, or I want to do a start up a new super specialty branch in that particular area, based on the requirements of the data, what has happened to the over a period of time, we can look into and go ahead and see and to do all these implementations. So we look at a surgeon, what are the basic surgeon needs? So we see what happens for a surgeon in his outpatient services. He depends on a lot of investigations and diagnostic modalities, his needs of IT in operation theater, data access, and also as a teacher. As a teacher or in the teaching profession. When you look into your electronic medical records or hospital management system investigations, they're all integrated. So if you have a patient coming into the clinic, so first it gets registered, and this is taken care by your hospital management system. It captures all your data related demographics, his registrations, and all that. And when a patient goes to a doctor, this information is all fed into the electronic medical records. The clinical information is entered by the doctor and it is available, and in case after the end of your investigations or after the end of your examination you advise treatment, the patient goes back into the HMS. If it could be a simple thing like an opticals, like has it been an ophthalmologist, it could be a very simple thing, patient comes only for a glasses, or it could be a surgery. So it goes back to HMS, he gets scheduled for surgery, or he goes to an optical stores and buys the glasses. But if the information is already there, the person who is dispensing the glasses does not re-enter all these information and he can dispense it automatically. Same thing when he has to go for investigations, it goes to diagnostic modalities. They perform the test and the tests are uploaded into the system and you can see them instantaneously. So this is what happens, and all three systems are integrated and they work in close collaboration so that it provides information at all levels. So why do we need EMR? So we take a case scenario at Shankar Nethralaya. We have more than 2 million files. We see about 1,200 patients per day. More than 100 surgeries are performed. It occupies huge storage space, and it takes time to pull and retrieve these files when the patient is available to you. So we had real challenges in getting these files at right time. We tried with a simple system like a file tracking system as a first thing, where we can actually barcode these files, identify where these files are stored. So when a patient comes, automatically I know this file is in that particular room and it could be achieved. This was the era when we had a paper records. But what happens? We also have new branches coming up. Patient hops between branches for various treatments. Some investigations may not be available in all centers, so they have to go and move to the other centers. Patient gets operated, they go and get a post-operative checkup done in other center. So the doctor needs to know the entire information. So this information, imagine if it is a paper record, we need to transport like a pizza corner boy taking the file from one center to other. Imagine it is in same Chennai locality, it's fine. But imagine if it is in different place like Kolkata or Rameshwaram or Tirupati, where we have new branches, the patient cannot, these files cannot be. So we have to either fax it, and this again is a tedious process. So with the electronic medical records, which is all centralized, these files can be accessed anywhere at any time. So that's the need for electronic medical records. But also very important, when we have it in paper, these data is untapped. Huge amount of data is there. We don't know why patient comes to the clinic, at what stage of the disease the patient comes, why is they benefited from the treatment. All this could not be analyzed. We can have so this data is untapped. So there's a huge treasure which is behind, which is not used at all. We want to look at the measuring the quality of care, looking at medical or surgical outcomes. We want to do a lot of research, and we don't know which patients are eligible for which studies. We can generate case series. We need to improve the quality of care. The patient's records has to be constantly audited to look at the quality is maintained at all levels. The junior doctors or the senior doctors who have been doing, we need to audit at least 10% of for various regulations to make sure this the quality is maintained. So that's why we need EMR. We also need EMR to reduce the cost and time saving. I skipped some of these slides because there is usually initial large investments involved, but the return on investment, most of the studies have proved that the return on investment is very highest if you have invested in electronic or HMS based systems, and they say you get it back within 5 years. Now the recent paper has said even 2 to 3 years you get back all the return on investments when you invested in HMS and EMR. Fine. We just looked at a small analysis to do a cost benefit analysis. So if you have looked at electronic medical records department, previously the paper records, it was occupying huge amount of space. So you can see the space on the right hand side. Every year we had to increase the space of the paper based medical records department, but when we started electronic medical records, the space was almost the same. So we could maintain the space, and it was like 6,000 square feet initially during the implementation of EMR. We also tried to put a cost to all these things, the storage or the rent value to the space, and once we started getting into electronic medical records, we hardly required about 100 to 200 square feet, and that could reduce the entire amount of space could be used for various other sources, and we could almost save about 69 lakhs just taking into the value of space and the manpower reduction, all that could be done. So now looking at time saving, does the electronic medical records or HMS really saves? Yes, it really saves time. The time benefits begin after all data entry is done, and it reduces your patient waiting time, time in locating record, time in dictating referral letters, time in writing prescriptions. All these are small amounts of time, but at the end of the day, all these if you add up, you can save at least 1 or 2 hours of time when you see the same patients with electronic medical records. So we did a study, and this was published to say that electronic medical records takes huge amount of time in data entry, but this was a big misnomer which we wanted to prove and say it is not. So we wanted to randomize it patients to paper-based records and electronic records, and we found that at the end of it, both of them were same. That means the amount of time when the patient enters in, the entire examination and writing findings are captured up to the complete. This includes like history taking, clinical examination, slit lamp examination, refraction, and appellation tonometry, and up to the time of dilatation, which we do routinely, which approximately takes about 20 minutes. So the same thing happened with electronic medical records, and we proved that there's no difference between the two. So that we wanted to prove the data entry when we do simultaneously doesn't really increases the time. So this is how a system works. So the patient gets registered, the patient is seen at the optometrist. As they do the examination, they also do the entry and simultaneously, and when the patient goes to the doctor record is automatically simultaneously available. He examines the patient, so this data entry happens simultaneously. We don't wait, send the patient out or do the data entry in a paper format and then send it later. So everything is done electronically. So when the patient goes to the doctor, he can see and he examines and puts it. So, but the problem we have is in ophthalmology we do a lot of drawings. So this was a big issue, and we could convert the entire desktop into a drawing pad using a small drawing pad. So we could do a beautiful diagrams and we could make that as an useful. So initially we tried with the tablet PCs, which was very costly, but with the desktop, with converting a small writing pad into a tablet was made it comfortable and was much acceptable, and the implementation was very simple when we did this. All these comes with challenges. A good successful implementation of HMS or EMR needs a good training. So we could do a lot of implementations. Currently, our EMR is used on a given day. Almost 2,000 users use this EMR. We have implemented about in 7 major hospitals, and all this was successful because of the simplicity and easy accessibility of the data, easy entry of data, and good training, which made this true for the success for this implementation. We also need to have a good help desk team and provide them with facilities for demo videos where they can access and do that. So these are all things which helps in easy implementation. There are challenges, there are financial challenges in development, because doctors want to keep on changing this should happen. So you need to have a strict guidelines what needs to be. They will have hundreds of wish lists. We need to identify and find out what could be done. So if you have an IT knowledge on the other side, you can know this is possible, this is not possible, but at the same time we should not neglect their wishes. So we should we should reply to them saying that which is possible, which is not possible, and a combination of all them. Real-time challenges with security, privacy and performance is all very important. A thumb rule in successful, as I said, identifying a champion user, phased implementation, good feedback system, attractive features, simple like how you use your Gmail or email. You make your patient record similar to that what we made, and we made the workflows as simple as what it was before, like in a paper record. So there was no change for a doctor. Instead of paper, they were able to see the same flow in the electronic medical record, so they could implement it very fast. So imagine we could implement this in 2006 when US were not even ready to implement. So we look back and say there were only 10% of hospitals had EMR in 2006, whereas they had the minimum. The new law act came late in 2008 or 10 to implement complete EMR in all hospitals, but we could do a complete 100% implementation well ahead in 2006 itself. Just give you a small example of how latest technology could also be used for improving workflows. This is like we do a cataract surgeries, like customized cataract surgeries, where even the smallest information is planned well, where the workflow is well defined. So here we have to know where to put our incisions to reduce the cylindrical power outcome after cataract surgery. So there were new instruments which came, which really did, like while operating I could also see where I have to put the incision. So this guides me where to put the line. So this is called an overlay. So this is like diagnostics, planning, and the treatment is even available at the theater. And coming to innovations in training. So when we look at training and teaching, so this is like the doctor is being trained with a goat's eye or a pig eye. So they are practicing the cataract surgery. We are live monitoring when the doctor is, so we assist, scrub in and assist and view from the side port. Now we also have a technology where it is like a 3-dimensional. Unfortunately this video is not working, where I can, like a video games, I can even do the entire cataract surgery and then get trained before I actually do on the live patient. So this improves the performance of. So this gives you a lot of information how my training is really. So the person doing the amount of time, how many mistakes they make, all that can be captured in this software. So this is a 3D, it's called a virtual reality cataract surgery. So we started implementing this and it has improved some of the important steps where they make a mistake. So that could be easily corrected. We were one of the first pioneers to implement teleophthalmology using satellite-based technology with ISRO. So, and the other important things as a surgeon, we also have web portal and video conferencing, which we do routinely. All our classes are transmitted to Sathya Center. So the ophthalmic classes, ophthalmology department here gets linked up regularly and every week, and we do video conferencing. And we also did this for All India Ophthalmic Society, where some of these, we have linked up major medical colleges, because unfortunately the teaching in most of the medical colleges is very poor. So we have a very good person. We wanted a good teacher. His knowledge has to be implemented to multiple students. So we looked up and we did a webinar. So and even the students could interact with the teacher. So this made this. So now the All India Ophthalmic Society is trying to plan up, at least identify the most important teachers and put these things on a routine basis. And the last important thing is a clinical decision support system, which we are working on. So this, like important complicated situations where our mind doesn't really help us. So it can import all these information into the clinical decision support system. So some investigations or some very rare cases, it can alert you what needs to be done at the next level. This also can be used for like we did this for a basic, like for a general practitioner who sees a patient, screens the patient for ophthalmic problem, may not have all these knowledge. When he enters, like he has decreased vision, on examination he had some opacity, all that, or he had an ulcer, how the ulcer looked like. If he enters, it automatically tells you need, it could be a bacterial keratitis or fungal corneal ulcer. So next step is you have to do a scraping and do all these things. So these kind of things could be done using a clinical decision support system. We also have something which is important called National Knowledge Network. All these things, we need a good database, a good network. So the National Knowledge Network is a high bandwidth fiber network which is provided by the Government of India, where they linked up all the major hospitals, major government institutions, IITs, which could be used for countrywide classrooms, multicasting, streaming videos, or for grid computing, or even for digital libraries could be used. This is almost 1 gigabyte per millisecond. And all these comes, as Charles Darwin said, it is not the strongest of the species that survives, not the most intelligent that survives, it is the one that is most adaptable to change. So the change is what is important when you look at IT. When IT has all these facilities, unless until you start adapting that, and the change is very important, so which will really help the patient and improve the quality of care. At the end of the day, we need to be a happy surgeon because you have a good, delighted patient who benefited with all these things. I thank once again the organizers for giving this opportunity.